filtering that our kidneys usually do. So where our kidneys are usually working and filtering out waste products and helping us maintain our fluid volume status and helping us make erythropoietin and helping us make calcitonin and calcitrol and helping us make renin, those things aren't happening anymore. So the dialysis machine can do the filtering, it can get rid of waste products, it can help us get rid of excess fluid. It does not change the fact that we don't make those proteins or hormones anymore. Okay, so the machine doesn't do that second part of it our kidneys used to do. It only can help us maintain that balance. So go back to our first slide. First PowerPoint where we said our kidneys do two things. Maintain balance and then make these proteins. So this machine is not going to make proteins for us. So we have to recognize that people that are on these machines still are anemic because they don't make erythropoietin. They still have trouble with their blood pressure because they're not producing enough renin to keep their blood pressure up. They still have problems with their bones because they're not making enough calcitrol. So while this machine does a lot for us, it can't do everything that our kidneys usually do. So that's just a picture of somebody hooked to a dialysis machine. Again, this is taken 3 days a week. If you're taking care of dialysis patients, you realize that before they go, many times they have a lot of extra volume. We weigh them every day. And when do we get their weight? Typically before they go in the morning for dialysis. Most of them go early in the morning. Sometimes it's afternoon, but majority of patients, we try to schedule as early as possible in the day. There are dialysis outpatient centers all over the place, right? People drive themselves there. They get to the machine, they drive themselves home. They got to be stable before they leave to go home. Again, usually you get to go out to observation and see that happen, and in real life, then we really actually see what happens when somebody gets put on dialysis. Of course, this year you're saying no because they don't want one more person in the facility that doesn't need to be there. So this is peritoneal. What do you think just from looking at this would be an advantage of peritoneal versus hemodialysis? This is happening here inside your body. The one biggest advantage, this person can usually do their dialysis sometimes overnight at home, so they might wake themselves up at 8 p.m. and sometimes at 8 a.m. What can they now do during the day? Work. So it makes it a little more of an advantage that the person can get up and walk around while they're getting this in, while it's infused, and we'll talk about how that happens. This person can get up in the morning and go to work, but then there's different ways of doing peritoneal. Most of the time, those patients are hooked up for 10 or 12 hours every night at home. Now think about the picture of that patient that's doing this at home. Doesn't it have to be somebody that cognitively knows what the heck's going on? That can hook themselves up to that machine, that can make sure when they hook up that it's nice and clean and it's surgically cleaned off and that they don't get an infection. So it can't be somebody at home that is confused, that has dementia, that doesn't have a good home life, that doesn't have a good home atmosphere to stay clean. And let's face it, there's a lot of people out there that don't. So we have to think about those risk factors: peritonitis, infection, people that don't really know how to do the exchanges properly. They could really mess it up. So it has to be somebody that is cognitively aware of how to do this for themselves. Can you have a nurse come in and do this at home and hook this up for you? You could. However, remember, most insurances are not going to cover a nurse coming in 7 days a week. So there's limitations with that too. Is this going to be paid for? How are you going to get the nurse there? Is she going to be there every night at 8 o'clock to hook you up? Most of the time, the patients with peritoneal are patients that can do it themselves. So while everybody always thinks, well, why wouldn't you do this? There are drawbacks to doing that, and it doesn't always work for the patient the best way. So many patients choose this because they can't either. Their insurance won't pay for this, they don't know how to do this, they don't have the resources to do this, they're not cognitively aware of doing this, they don't want to do it themselves. So again, there's choices that are made with the patient and the physician on which type of dialysis is going to work best for this patient. There's two different types, and sometimes people are on this, sometimes they're on this. They're not on both, they're on one or the other. All right, so why is this not moving? Okay, so what happens with dialysis? The purification of the blood by the dialysis machine itself. This person's blood is actually filtered through this machine. The machine does the work of filtering out the waste products, balancing the electrolytes. I don't know how it works. I'm not a dialysis nurse, so I can't stand here and explain to you how it works. But the doctor will order certain solutions that are more, remember how I said some are more hypotonic or hypertonic? Depending on the solution that the blood goes through, it mixes with the solution in this machine, and that solution, depending on the concentration of it, usually cools out excess fluid out of the patient's volume, and only so much is put back in, and it's more concentrated when it's put back in. I'm trying to make it as simple as possible. Again, I don't claim to be a dialysis nurse. Some people really love it. They have patients and they do it for years and years and years, and this is what they do every single day. It's not something I would want to do every day. So again, this blood, their blood is filtered through this machine. Electrolytes or waste products are removed, electrolytes are stabilized, the blood line is, the blood goes back into the patient after the concentration of that blood is exchanged and fixed, basically. So this machine does the filtering for the patient. Again, I know it's like very simple. There's certain processes with dialysis, depending on what the doctor orders. What's the percentage of the solution you're getting? What's the potassium? Well, there's certain things in the dialysis solution that remove more potassium or less potassium, or more sodium or less sodium. Again, we're not doing dialysis, we just need to understand the principles of it. So the patient is hooked. Remember what I said yesterday, the gold standard, what we want to get to, the easiest thing to use is the AV fistula. Pick that up, that's what we want to have in the patient. Why? Because we can use it long term. An AV fistula can be used for years. I'll show you a picture here of different types of catheters. We can put a subclavian catheter. We can put a Hickman. There's different catheters depending on who makes it and the name of the catheter. One thing with those catheters, they don't last as long as the fistula. They can become infected. They can create sepsis for the patient and a bacterial infection in their blood. The fistula is the easiest way to dialysis for the longest period of time possible. What is a fistula? It's usually put in the arm, forearm, or upper arm. It's usually most where we see them happen. And what is created is it's recirculated. So we create an opening that we can hook to an artery and to a vein. And we give the solution through the artery, circulates through the body, and then brought back through the vein part of it back to the machine. So that's why it's called AV fistula. There's an arterial part to it and a venous part to it. And I'll show you in a minute. We create that surgery, the doctor does. And then that is what's used for the patient to get dialysis. So every time they go to dialysis, that area is cleaned off, surgically cleaned, not just wiped with an alcohol. It's cleaned with a surgical asepsis procedure, right? Sterile gloves, clean with betadine, HIPAA, what they're using, and then the patient gets hooked up to the machine. And then when they're done, they unhook that. What's our risk? Right now, if we already know that we stuck a catheter into an artery, what's the risk going to be after the patient's not completed? So we don't just send the patient home 5 minutes after they come off the machine. Everybody with me, you got to make sure the arterial part of it has clotted off and they're not bleeding anymore before they go driving down the road and go home. Okay, it makes sense. They could bleed to death. So we have to make sure that homeostasis, that the patient's balance, that their blood pressure is okay, that there's not blood coming out of that fistula in their arm. So again, remember, dialysis doesn't replace the hormones. It doesn't make our kidneys make those hormones. If our kidneys aren't working, the hormones aren't there. What does that mean to you if the kidneys are no longer making calciferol and helping us absorb calcium and vitamin D? Well, the patient's going to have weak, brittle bones. That's your dialysis patient. Do we have to supplement and give them calcium? Yes, we do most of the time. Do we have to give them vitamin D? Yeah, because they're not making enough of it already. What about the renin part of it? Because they don't make renin, and renin causes vasoconstriction, and that makes our blood pressure stay up. What do you think about the dialysis patient? Where normally is their blood pressure? Low. On the lower side, because they don't make renin. Renin creates vasoconstriction. Renin makes our blood pressure stay up. So many times, the dialysis patient has a lower blood pressure. And they'll say to you, hey, that's normal for me. Now remember, I said many times, what do you think the blood pressure is going to be like? And you are going to be right, Stephanie, where by saying, before they get to dialysis and they have all this excess fluid that needs to be removed, where do you think the blood pressure is going to be? A little bit higher. Does that make sense? Too much fluid volume is going to make the blood pressure a little bit higher. Most of the time, those dialysis patients have a lower blood pressure. One of the complications that happens when they're on the dialysis machine is we take out too much fluid volume with the machine too quickly. And the patient's blood pressure drops. And sometimes patients actually code on a dialysis machine. So while you think, okay, that seems like a pretty simple job, it really is not as simple as it seems, because you're removing a lot of fluid in a period of 3 or 4 hours. You have to be careful. So the patient is closely monitored for blood pressure, heart rate, level of consciousness, the entire time they're on that machine. And I've had patients where, I'm working at Ken or Christiana, and they call code blue on dialysis. The reason why, probably too much volume is removed too quickly. The patient can't tolerate the decrease in their blood pressure. So two different types. What's the function? Rids the body of excess fluid and electrolytes, helps us achieve acid-base balance, eliminates waste products, restores homeostasis. So doesn't that look like all the things that our kidneys normally do for us? That's what dialysis now does. Dialysis, when the patients miss it, even if they miss just one, suppose there's a huge snowstorm, they can get very sick. And that happens sometimes where a patient can't get out to dialysis, or for whatever reason they didn't show up to dialysis. People decide, I'm not going to go today. And so then what do you think is happening? The dialysis nurse is calling them saying, where are you? You need to be here. Today's your day. And well, I'm going to come on Friday. By the time Friday comes, sometimes they're going into fluid overload. They might have trouble breathing. Their blood pressure might not be stable. Like lots of things can go wrong if this patient doesn't get there. So you have to recognize that dialysis, sure, you can maybe miss one, miss two, or you miss a week, you're going to be pretty darn sick and probably end up in the hospital. This has to happen because your kidneys aren't working. Remember, by the time you start dialysis, your creatinine is 10. So what does that tell you about your kidneys? They're not working. So here's the functions. This is what it does. All we're going to do is go through the two different types and then kind of what they look like, what we would expect this is doing for this patient because the kidneys aren't working anymore. All the same stuff, same things that our kidneys normally do. Every day your kidneys process about 200 parts of blood. I said 12 times in an hour, the circulation goes through your kidneys. When your kidneys aren't working, this is not happening for this patient. So they have to go to dialysis to get these waste products off. What do you think their electrolytes are going to look like? Are they going to be high? Are they going to be low by the time they are arriving to the dialysis place? High. They're going to be high because what is normally our kidneys doing for us? Regulating all those levels, right? Helping us get rid of excess potassium that maybe we have in our system that we got in our diet. What do you think about their BUN and creatinine? Where are they going to be? Up or down? Up. They're all going to be up. Right? Those numbers are going to be up. The electrolytes are going to be up. What about their weight before they get dialysis? We're getting their weight at 6 a.m. They're going to get dialysis at 7. Is their weight going to be up or going to be down? It's going to be up. That's what we expect. So now we put them on the machine. Now where all the numbers are going to be? Back to normal range. Their weight's going to be back down. Remember, we're going to get them on the scale every day. We're going to get them before they get dialysis. We're going to weigh them afterwards. What about their abdominal girth if they have a lot of excess volume in there? Where's that going to be before they go to dialysis? It's going to be higher, right? Now they get dialysis and we measure their stomach and their ascites. Where do you think that's going to be? Down a little bit. That's what we want to happen. That's what dialysis does for us. We're not giving anybody extra volume when we put them on dialysis. We're actually cooling off a lot of them. Can we give patients blood when they get dialysis? Yes, we talked about that yesterday. How would we know they need blood? As soon as people get to dialysis, and I wish you guys could get out, you'll see what I mean. As soon as they get there, they get all kinds of labs on the patient. Do you think they have to stick the patient? No, they just use the fistula. Does that make sense? They put them on the machine, they draw blood from their vein, and they right away, running it through the machines that they have there. Before they even start, they got a potassium, they got a sodium, they got a hemoglobin, they got a hematocrit. They know what the patient's going to need that day. And then they adjust the order. So the doctor will say, if this, and this is what should be in that dialysis solution based off of the labs that the patient has today. And that's how dialysis works every day. So who needs dialysis? It's hard for you to see this, but basically it's AEIOU. So who is A? Acid-base problem. So that's your person that is extremely acidic or extremely alkaline. So what if, go back to what we learned about acid-base stuff, and what if your patient all of a sudden overdosed? They normally don't have bad kidneys, but they overdosed on the street and they took a lot of street drugs and they came in and their pH is 7.12. Is that too high or too low? Too low. What's normal? 7.35 to 7.45, right? Here's your picture. This patient, let's make him 6.9 because that's life-threatening. That's really low. We might have to send them to dialysis. Why? What do we say our lungs do first? They kick in first. But if our lungs aren't kicking in time, the patient's going to die. Wouldn't we want to filter out what's in their body, all that heroin, cocaine, whatever it is that they took? So when we send somebody to dialysis, sometimes it's a chronic issue. Sometimes it's a patient that maybe only needs dialysis once or twice in order to save their life. We got to get that cocaine out of their system because they completely overdosed on whatever drug they're taking. Does that make sense? So sometimes people can acutely get dialysis. Sometimes lithium is a medication we use for bipolar disorder, for people with mental health. I was just watching Grey's Anatomy the other night. The patient had a huge high lithium level, and the doctor immediately ordered dialysis. And I was thinking about this PowerPoint. I was like, yep, this is why. Lithium level, 0.4 to 1. 1 is our normal lithium level. We haven't talked about lithium yet, so don't say, oh my God, I didn't know that one. You will. But if the patient has too much lithium in their system, how are we going to get it out of their kidneys and out of their body? We might have to send them to dialysis because we're going to save their life. We're going to have seizure or go in a coma. Same thing for other medications. What if they have too much digoxin? Remember, we said normal digoxin. What is that normal number? 0.5 to 2.0, I think. What if the patient's dig level is 8 when they come in because they took a whole bottle of it? Right? Sometimes these crazy things happen. Sometimes the patient is older and doesn't know that that's not Tylenol. And I took 6 of these yesterday. That stuff like that happens, and then we have to send them to dialysis. So don't think it's just chronic renal people that get dialysis. Sometimes we use it to help save people's lives. Somebody with electrolyte problems, that's the E part of it. So there is your person that might have a potassium that's 6.8 and their heart rate is 20. We might immediately put them on a dialysis machine. Do you think we have time to put a fistula in and wait for that fistula to work? How would we do dialysis for that patient? We put that catheter in their chest because we can put that in pretty darn quick. Take them downstairs to dialysis at Christiana. We send people from the ICU lots of times from the ER. Put a big central line in. It's not going to be through an IV in their arm. We need a bigger catheter and we send them to dialysis. Okay, there's the next one, I. There's your intoxication. That's your drug people. That's your people that if we don't get this drug out of their system right now, they're going to die. So we got to take them to dialysis. That could be digoxin, that could be lithium, that could be street drugs, it could be anything that's life-threatening to that patient. Your O is a person that's overloaded with fluids. So that's a person that has too much fluid volume. What kind of condition of our heart would create excess fluid volume? Congestive heart failure. So do we sometimes have to put these people on dialysis? Yes. If we can't get rid of all the excess volume of Lasix or Renal or other diuretics or digoxin to make it pump fit better, we sometimes have to take them. And the last one is uremic symptoms, and all that really means is kidney symptoms. And we'll talk about what uremic symptoms are, meaning your kidneys are shutting down. So here's our people who need dialysis. These are the patients that fall in the category. Why would we even put on a dialysis machine to start with? So here's our fistula. Let me show you a picture of it. This is called a fistula. AV meaning arteriovenous fistula. That's what it stands for. So This is surgically created, again, usually it's this part of the arm or the upper part of the arm. What do you know about fistulas if you're the nurse taking care of somebody with a fistula? What are you not going to do in that arm? Take a blood pressure. No blood pressures. Remember this the rest of your nursing life. No blood pressures in that arm. So how are you going to know? Well, find out in the history of the patient you're about to take care of. What if I have 19 people? Well, you better find out who has your fistula in the arm. If you find out it's a chronic renal patient, ask them, do you have a fistula somewhere? Try to remember to tell people that in a report, right? When you give a report on somebody, just think about what do we not know or what do we not do sometimes. If they have a sleeve on or shirt on, do we always know? No. So what do we like to tell people to do? Put that wristband on. Remember, you ever seen anybody with an orange wristband or some kind of wristband that says no blood pressures in that arm? If the patient has a fistula, there should be some identification for that patient put on their arm. That's the best way of everybody knowing when they go in that room, don't do blood pressures. If the patient's awake, alert, oriented, they will tell you most of the time, hey, I can't have blood pressures in that arm. But this is something just to think about. Make sure you communicate. And I say this is utopia. This is what it should happen. Does it always happen? No. So if you find out the patient has a fistula or you think they're on dialysis, ask, where's their dialysis access? Oh, it's in the left upper arm. Well, I better not be getting a blood pressure in that arm because I could potentially damage this fistula that's in. And then the patient would have to go back to surgery and get another fistula put in. So really all this is there's a connection made underneath the skin surgically between that artery and that vein. And so the arterial part of it, the blood comes from the dialysis machine through the artery. Remember, our arteries circulate the blood just like our heart does, circulate it through our heart, through our body. The venous part of it brings the blood back to the dialysis machine. So there's two different, there's usually a blue and a red little tap that are kept on the end, and the patient is connected to the machine with two different sets of tubes. So one goes to the artery part, one goes to the vein. That's how the fistula gets. So blood from the dialysis machine goes into the arterial part, it goes through the body, circulates through the body, comes back to the machine through the venous part of it. So all of the filtering is done through the kidneys. So here's our artery and vein, blood from the dialysis machine coming in, blood going back, this is the graft. This is another form of a catheter. So here's our gold standard, the AV fistula. That's the best thing. It's made by joining an artery and vein together under the skin. And they're joined. This allows us to get access to the arterial and venous circulation in the patient's body. Look how long it usually takes for this to what we call mature. Be working, be functional, 3 to 4 months. What are we going to do for dialysis in the meantime while this is waiting to actually get fully formed with good circulation? A subclavian, a different type of catheter, right? There's a picture of a different type. Anybody ever seen somebody with a chest catheter in? There's many different types. Usually they use this subclavian vein right here because it's a bigger vein. Don't use a small vein in your arm, it's not going to last. This is inserted for short-term or temporary use until the fistula starts working, and that could take 3 to 4 months. So your gold standard for NCLEX in real life is get a fistula in this patient. Again, there's a plastic tube that connects underneath the skin that allows the artery and vein to connect. And it takes us about 3 to 4 months before that is working. How do we know that that's working for us to use? How do you think we would know? Anybody ever felt a fistula in somebody's arm? That's how do you feel? Okay. It's hard. How should it normally feel? It should feel soft. Over time, many times that fistula kind of sticks up out of the skin. It's usually inserted under the skin, but as it matures, look what happens. I should say it on here somewhere. Okay, when the artery and vein join, the pressure inside the vein increases. Because remember, normally do we have a lot of pressure in our veins? No, more pressure in our arteries. So what happens? The circulation kind of reroutes itself. We want to call it that. And the fistula itself will mature and get a little bit bigger and bigger. Sometimes people have fistulas for years and you see them sticking out of their skin. You'll see them. They're okay. How do we know they're okay? You put your fingers over top of the fistula. You should feel a thrill. It's called a thrill. You should feel the circulation going through there. With your stethoscope over the fistula, you should hear what's called a brewing. So you feel a thrill, hear a brewing. Write that down, because that's something we're gonna have to remember the rest of your life for somebody with a fistula. Feel a thrill, hear a brewing. So what do you do? Somebody has a fistula. This is everyday 101 nursing. If they have a fistula, you should be checking it every single time you go in that room when you're doing your assessment patient. They have a fistula. Put your fingers over it, and you'll feel it. You'll feel like that squishing sound. It's the circulation coming through there. That means it's working. That means it's good. And the doctor will decide, okay, the fistula is fully matured. We can use that for dialysis now. In the meantime, we're going to use a different type of catheter until the fistula has completely, the circulation has completely rerouted and it's good to use. And again, this takes about 3 or 4 months. Your body kind of does this on its own. So basically, again, you're not ever going to be putting one in unless you become a vascular surgeon. All we really need to recognize is there's an artery and vein going together under the skin. The circulation is kind of, normally arteries and veins don't come in contact with each other. With a fistula, they do in that particular section, and that's how we do dialysis. So it's kind of a rerouting of the circulation in that area. It takes about 3 or 4 months to heal. We're not going to do blood pressures in that arm. We're going to feel a thrill and hear a buoy. We should do it every 4 hours, at least once a day, make sure it's working. How else are we going to know that that fistula has the circulation is clouded off and is not functioning like it should? What do you think their hand's going to look like? Pale, blue. What about their radial pulse? If they have a fistula here, wouldn't we want to be checking their radial pulse pretty frequently? So when you know there's a fistula, check the pulse. Make sure they have a good pulse. Make sure you feel the thrill in the fistula. Put your stethoscope on. You would hear swish, swish, swish going through it. That's hearing a brewer. That's what it's called. You're doing this when somebody has a fistula. When somebody would go in for dialysis, that's the first thing the nurse is going to do before they hook them up. Make sure that fistula is working. Because what can happen? They can clot off. And like you're saying, Mackenzie, people can come in. I've had this fistula in for 8 years, and now it's hard and it's not working. My hand's getting cold. I'm starting to lose circulation in my hand. What is going to happen? We're going to lose circulation to their hand. So that fistula has to be removed and another one put in. It stopped working. And again, fistulas can last for years. Some fistulas only last for 6 months. It just didn't heal the right way, or clotted off, and may not be the patient's fault. So again, this is what a fistula is. This is the best scenario because it lasts the longest, and we can usually leave it in for a long period of time on dialysis. So it's a direct connection of an artery to a vein. This is not normally happening in our body. Once it matures, that's what it's called. That means it's fully healed and working the right way. We can use it. Look how long it can last for decades. It can last for years and years and years for that dialysis patient. It can take weeks. It can take up to 3 or 4 months for it to be fully ready. But remember, this is our gold standard. That's what we want in the National Kidney Foundation. If you're going to be on dialysis, it's going to say, hey, what's the plan? You're getting a fistula put in. Because this type of catheter can only work so long and would have to be removed. And it might be 3 months, it might be 4 months, but it's not going to be able to stay in forever. It's going to create an infection. This can only be left in place up to 6 weeks, and now we're going to change it again. So you can imagine the patient getting dialysis does not want this put in every 6 or 8 weeks, 3 months. They want something that's going to last long. So that's what this fistula does. Everybody okay with fistulas? What we're doing with it, what our assessment would be, yeah? It could be up here. Yeah, it could be up here more. I've had patients with leg, but again, think of the scenario of having it in your leg. It's more problems with walking, getting in the way, not being as comfortable. Usually the arms are used for the patient. So this is what you're doing. Feeling a thrill, hearing a bruit. A bruit is a sound, so don't get confused on which one is which. a sound that you're gonna put your stethoscope right over top of that fistula, and you're gonna hear like a squishing. It almost sounds like a murmur, but it's really pretty loud most of the time. What are some of our complications of having a fistula? It can clot off, it can become non-functioning, it can cut off circulation to the hand. So we have to remember, this is a picture of a fistula. See how it's stuck outside the patient's skin? But now it looks pretty infected, right? It's red, the skin is red. That's a fistula that probably has to come out, because it shouldn't look red like that. It does stick up sometimes, but the skin itself many times is intact and looks like normal skin. You just see this, there's a little plastic piece in there that basically creates the circulation in the artery. This is a rash around where the fistula is. You're hard to see on that picture. See this fistula here? Can you see that in their arm? It's not a vein that's just big and sticking out. There's a fistula underneath of the skin. So what I would do if I was a nurse, I would go in and check their radial pulse. Do they have a good radial pulse? Is it the same as the other side? Does that make a difference? Yeah, it does. Shouldn't it be the same? Yeah, it should. Then I'm going to put my hand over top of that fistula, and what am I feeling? I'm feeling for a thrill. That's what it's called. You would document if somebody has a fistula in your notes, probably on a computer chart now, positive thrill, positive thrilling. What does that even mean? That just means it's working. If it said negative thrill, I can't feel anything, what would be my answer on NCLEX and real life? I would be calling the doctor, because the circulation is not, you understand what I'm saying? It's going to cut off the circulation in their hand. So positive thrill and brewery is important. That's important for us to know.
So does the skin grow over top of it?
Okay. The skin will grow back over top of it. All it is a little incision, and then they insert this plastic device that basically is a graft and creates a graft between the artery and the vein. Because normally, does our arteries and vein come in contact? No. One takes blood from, one brings blood back. With this, it's kind of rerouted. Does that make sense? So this is how we do dialysis. So again, a dialysis nurse is going to be trained. You don't just walk in and know how to do dialysis. You're going to be trained on how to access the arterial part and the venous part of this. And then that's how they figure out how to hook to the machine. So that's a fistula where I would walk in on the nurse, check her radial pulse. What's her hand look like? Do they have good circulation? Does her hand feel cold to touch? Do they have pins and needles in their hand, right? None of our assessment is different than what we would normally be doing, but now we're going to feel for the thrill, put our stethoscope right on top of the fistula, and we'll hear that murmuring, and that's good. That's what we want. See how the graft is under the skin? That's just showing you kind of how it's created surgically. And then the skin, usually, there's only a small incision, it just peels off and goes back on the top of it. Okay? Everybody okay with the fistula? This is just showing you another picture.
Do we have to take like medicines to prevent from reactions from foreign bodies?
So when somebody gets put on dialysis, I'm sorry, I'll talk about that in just a second. When they're done dialysis, what do you think the nurse is going to inject into that fistula kind of at the end of dialysis? Some kind of anticoagulant. Does that, like heparin or something? Right into the fistula to keep her from clotting off. It's not going to be a high dose heparin. It's not going to mean that the whole blood is thinned. It just thins around that fistula, so clots are less likely to form, basically. So right before they're done, sometimes we'll inject, almost always inject a little bit of heparin to hopefully prevent a little clot from forming in there. Can clots still form? Yes, they can. So was that your question? What are we trying to do to prevent complications with it? We're trying to prevent clots. We clean it off surgically, so we try to prevent infection. Can they get infected? Yes, they can. So then they got to come out. Look at how here they're using the cephalic vein. That's right in the part of your arm here. Here's a basilic vein right on the inside of your forearm right here. And that's usually where they use it. I've seen fissulas up here and fissulas down here most of the time. What was your question? Did I answer your question?
This kind of foreign
body in your body for so long. Is that going to create an issue sometimes? Most of the time, your body kind of adjusts to that little piece being in there and it's a graft. So you don't, yes, you can reject it, but most of the time the patient's okay because it's only a small thing. It's not like a whole organ that we're giving you. Right? So many times the patient's perfect.
So, is there something, is there a piece they're putting in there to connect all the things?
Which is some kind of graft, or they sometimes surgically connect those. Most of the time, there's either a graft or a mesh or a plastic tube that's put in there. Something connects the arteries and the veins together.
Okay, we're not using the actual part of it.
No, usually there's a connection piece to kind of reroute the circulation, right? And again, I'm no vascular surgeon. Obviously, with medicine, things change and they get better at doing these things. All I know is that patients I've taken care of, some will say, look, they have an AV graft. Well, that means there's some kind of graft that's put in that connects, and it could be just a wire mesh graft. There are some people that get like that tube under the skin, depending on the vascular surgeon and what they like to use. It just depends on what kind of AV graft or fistula they need. So yes, there is something that's put in there surgically that connects these two things. It creates like a different kind of reroutes the circulation. Again, here's our complications. When they become clogged or narrowed, obviously we have problems with circulation. They can get a clog and then couldn't we possibly have a clog that moves somewhere that was created in this fistula and creates an embolism? Yes. Not likely to happen because we a lot of times the dialysis nurse does it. If they're going to hook them up to the machine, they're going to hope that that fistula is working. And if they're getting a clot or they're getting pressure, they're not going to push with all their might and push the clot somewhere else. They would have to have it dissolve in this machine. And again, you're trained as a dialysis nurse on things that could potentially be your issues or complications that can happen. Points for dialysis, what we're going to need to recognize if we have a dialysis patient. We're going to weigh them before they go. We're going to weigh them after. What kind of scale are we using? Use the same scale, right? We said that before. Don't use two different scales because you're not going to get a different number or comparison. Monitor the blood pressure during the whole dialysis procedure. So these people, when they're hooked to dialysis, have constant blood pressure monitoring. Why do you think they have? We have to do that. In case the blood pressure is dropping while they're getting dialysis, and they start at 120 over 80, and now they're 110 over 70, and 2 hours into dialysis, they're 80 over 40. What do you think the dialysis nurse is going to do? Stop the dialysis. Put the patient into a lower position. Maybe you have to give them IV fluids because we remove too much volume too quickly. These are things that can happen during dialysis. Before we hook them up, we make sure that we access the site, clean it off with surgical asepsis so it doesn't get infected. Make sure that we have a drill and buoy and the fistula is working before we use it. Here's our key points for us. We're nurses at the bedside. No blood pressures in that arm where the fistula is. If the patient needs to have blood drawn, no blood drawn in that arm. Most of these patients get blood drawn when they get to the dialysis. So what if they weren't going until Wednesday and we needed to get blood on Tuesday? Don't stick that arm. Use the other arm. Because you don't want to cause any problems with circulation in that arm that has a fistula. You don't want to be the reason why that arm got infected because we stuck that arm with a needle. We don't want to decrease circulation in that arm by sticking that arm with drawing blood. Use the other arm. Post a sign above the door. That's what I was just talking about. Put a sign, put a wristband on the patient. Christiana used to use orange wristbands that we would put on the person and it would say, no VPs or needle sticks in this arm. That's what you should see. That would be your best option. Do some of these like assisted living, assisted home, do they always have that on your arm? No. So you just kind of you have to be aware. This person gets dialysis, where's their access? Oh, it's in the right arm. Okay, I'm going to use the right arm. Dialysis patients, do we want them to drink fluid all day long? Why not? Too much fluid, what's not happening? Their kidneys aren't maintaining balance. Do we want to give them a water pitcher at the bedside? No. We want to regulate how much they're taking in because isn't that what our kidneys do anyway? So if our kidneys aren't working, we're not going to say to you, here, have 8-10 glasses of water per day. What's going to happen to them before they get to the next dialysis? Bless you. You're going to have too much fluid. So we have to maintain fluid restrictions. Again, way before and after. The meds get a little bit tricky. Should we give meds or shouldn't we give meds before they go to dialysis? We're talking about the blood pressure meds in the morning. But remember, one of those factors for renal disease is hypertension, right? Do they get their meds? Don't they get their meds? Most of the time, they're holding their meds. Why? You're about to pull all this volume. And if they get their meds at 8 o'clock, I'm going to the dialysis machine at 8:30. What is not happening? The med's not absorbed anyway. Everybody with me? So certain meds that we do or don't give. And again, most medications in the morning before dialysis or right before we send them, what if they're not going until 1 o'clock? And I go out and I say, hey, you want them to have that 8 a.m. And most of the time I say yes, because if I give it to them at 8, isn't it absorbed before 1 o'clock? If I know my patients on first thing in the morning, I give them 14 days, and I say, the ambulance is here to take care of you, right? Did I do anything? Did I give them anything? Did they absorb them? No. If I give them blood pressure meds at 7 a.m., I think I'm doing the right thing, and the ambulance is here at 8. Now what happens to their blood pressure by that 8:30? Isn't it going to start dropping? And now I'm going to the machine. Is it going to drop even more? Like, if everybody with us, you have to think about what's going on. If you're not sure, verify with the physician. Most of the time, most women that are in the morning. So now that we've been in the patient with dialysis for age 12, and now they came back, oh, now they're for the blood pressure meds again at 6 p.m., but that's what I give them. Their morning meds? Do I give them then and give them their morning meds too? No. So you have to figure out what the plan is going to be as a patient. What do you want to take the blood pressure like that? What do you assume that they're going to be a little bit lower because they just remove 4 pounds of fluid from the patient? Most of the time, those blood pressure meds are not. Most of the time. What if they came back to your blood pressure is 170? I'd be on the phone saying, hey, I'm going to give them this okay that I give their meds. Sometimes we would have to adjust our evening meds and give them their morning meds. Again, there's no way 100% of the time what we do. What's happening with your patient? What's your vital signs? What's good with this patient? If they come back to you from dialysis and they're tired, blood pressure is 90, don't go back on the morning meds because your highlighter is red right on your nutrition screen, right? What's happening with that? What's your blood pressure? Use your brain and think about it. Should they have this? Should I wait until 8 midnight and do it again? I'm not going to monitor blood pressure. Everybody knows this. We gotta have a brain first. You gotta think what's happening with the person. Okay, they went to dialysis. Should they get their meds? Now, what if they have meds like, say, Parkinson's or something else that they take? Sometimes people have like 45% that. What are you going to do with those meds? If they're doing the morning, you're going to dialysis in and out. Those meds? No. Because what is happening with the machine? It's releasing everything built into the system. What if I'm getting a Parkinson's meds and they come back? Yeah. Is that affecting your blood pressure? No. Okay, so it's just one by one, look at the meds and say, hey, this person still needs this. So I'm going to wait until they come back from dialysis again. Everybody with me? This is going to happen to you when you actually become a nurse. Yes, give these people, should I give these meds? Are all the meds held in the morning? What time do they go to dialysis? What's the story that they take to work right inside of that meds? A couple more slides and then we'll be done. A lot more of that. So here's our patient with dialysis. Talking about monitoring the blood pressure, it's laying on the floor after frequent vital signs. When we come back to you for dialysis, or we're working at wherever the shift that puts them, we're going to check the blood pressure. What do you expect it to be if they were 140 over 80 before they left? You think it's going to be higher or going to be lower? It's going to be lower. What is dialysis doing? They're removing the fluid from the patient. So that has us on. How do you think they're going to feel? You ever take care of a patient when they come back to dialysis? How do they feel? They're always tired. They feel weak. I just want to rest. They like come out. This machine for 4 to 5 hours is doing a lot of work for the patient. Basically 2 or 3 days worth of work for their kidneys. So think about how much is happening in those 4 hours. You're tired. I want to rest. It's not your patient that says, okay, we're going to go to TJ and TJ. What do they think they're going to say? I can't go. I'm tired. So try to think about what am I scheduling, what's happening. Maybe this afternoon is not a lot of signs regularly, monitor the patient. Monitor them for infections, if they just went to dialysis, or are infected. Any of these things are complications and things that we would be monitoring the patient for. Do the dialysis patient make urine? Can they make urine? They can. Is it usually a lot? No. Would it be typical for them to make less than 100 a day? Yes. Would it be okay for them to only have 200 in the last 4 hours or 8 hours? Yes. You don't have to call a doctor and tell them. They're going to say, why are you calling me? This is the dialysis machine did it for them. That's normal for that patient, okay? Sometimes when patients go to dialysis, you'll notice after they come back, maybe they